Yes.
Thank you. Professor Davies, I just have a handful of questions which do range across all of your evidence, so it covers a variety of matters. First of all, in one of your answers, you referred to hepatitis being caused by alcohol. Is it right that by that you mean inflammation of the liver caused by alcohol as distinct from infectious hepatitis?
Yes, I was brought up to understand itis as inflammation with many causes.
Also in your evidence, you talked about liver function tests. You talked about donors being excluded due to abnormal liver function tests. Other evidence to the inquiry has indicated that that wasn't routinely done in the North London Centre. It was only done if there was post-transfusion hepatitis inquiries. Can you assist us with why you thought liver function tests were being done, how you came to that understanding?
So I apologise if I have misremembered. I warned you my memory is not the world's best. But my training in haematology was at the Middlesex, and the haematology department was downstairs, and Vane, who discovered the Vane particle of hepatitis B, was on the third floor. So there were always discussions about none A, none B, and that was how I understood about the LFTs, and I had thought that that was the case. I apologise.
In your evidence, you spoke of patients losing the social memory of haemophilia without treatment. Is it right, though, that you have no first-hand knowledge of what patients with haemophilia did or didn't experience, or indeed what social memory they may have had or not had?
I did look after some haemophilia patients as a trainee, so I remember seeing some of the dreadful joints and hearing stories about relatives from them, but I did not look after any as they deteriorated and died.
In relation, though, to your evidence in relation to the social memory point, would it be fair that that was probably no more than speculation or assumption in relation to the later years?
When I talked to the patients, most of them were remembering that it had been bad, but they were in the stage of prophylaxis.
In terms of your CMO role, given that you had previously and were a haematologist as a clinician, why didn't you consider a health campaign in relation to hepatitis C?
I have always worked extraordinarily hard, well over time, for my patients and the public. And you can't do everything, and this was not put to me as a suggestion, and it did not arise from my background. My sickle cell patients, as I've said, did not appear to have hepatitis C, so it was not at the forefront of my mind.
Did you have any role or involvement in relation to the Penrose inquiry while you were CMO?
None at all.
And did you or your team consider the Penrose report and its recommendation to offer tests for hepatitis C to people who'd received transfusions in Scotland?
The policy team will have looked at that.
But do you think it came across your desk?
I don't remember a formal discussion about it. Clearly there were comments, and in fact I don't remember that they recommended testing.
You spoke about racial inequalities in practice. Was that something you then examined or looked at during your time as CMO at all?
To a certain extent. It took me some time to get on top of all the public health issues that you have as CMO, not coming from that background, and then to really understand. But you can see in my reports concern about health inequalities, a chapter, for instance, on violence with women and other things. I've addressed it most since I stepped down and wrote a book that was published in 2020.
And finally, in relation to your evidence that you would hold truth to power, how would you resolve a situation where you disagreed with the government's approach to an issue involving the health of the nation?
So, I was there to advise, and ministers had to decide. And some things maybe I would have done differently, but that was their democratic right. There were a couple of things, as I said earlier, which I felt strongly about, but when we discussed it and I explained how strongly I felt and why, with the evidence, they accepted. So it didn't get to a difficult, well, that was tough, but it didn't get to parting of ways.
So those are the questions I have from those behind me. I'm just going to check whether Professor Davies' representative has anything they would like me to raise. Sir, do you have anything you would like to raise?
Yes, I do. It really arises out of your cri de coeur that it is very difficult to change hearts and minds. The reason I ask is that I remember in recent times having been to a health education forum at which the subject for discussion, the seminar, was all about inquiries that there had been into the NHS. And I remember the chair observing that it seemed that almost every inquiry had ended up saying that the culture needed to change. Whether it's hearts and minds are the same as culture, certainly they're very close. You said it was difficult. You didn't say it was impossible. How do you go about it?
So I think it depends on the issue. So let me take one issue. In sickle cell, there was not antenatal screening for women who might have sickle cell trait to see whether they had, and then whether the partner had, to offer prenatal diagnosis or at least the understanding that they could have a sickle cell child. We brought it in and we talked about it, but it was not being picked up everywhere. Then I was asked by patients, or no, they aren't patients, women who had sickle cell children that were not, and they expected, to assist as an expert witness and speak to that, and I did, and they were, you would know as a lawyer, wrongful birth cases, and I chose to do that because I felt that it was one way to shift hospital management to saying, they've been talking about this, but now we could lose a case and have to pay out money. We'd be better paying it to provide that service. So you can do things, what I would call structurally. You can do things structurally through now IT systems, which say, you want to do this. Well, you can't unless you've done that. But in general, it's much more about culture. And that's partly how we train our clinicians, much more multidisciplinary, which is good. But we also need to train our clinicians to ask questions and be open to challenge. I was very lucky. I had a visit for 3 weeks from one of the top sickle cell doctors in the States, Professor Charash, who was at Johns Hopkins. And he not only went on the ward rounds with us and gave advice then, at the end of every ward round, he would sit down one-to-one with me and say, now, and interrogate me and advise me about the interactions and the evidence. So he helped train me to be much more open to the team about the interaction and the team and the patient challenging me and asking me. So there are ways you can train people and help them. My way of going round about the guidelines for sickle was another way of doing it. You can do it through meetings, but you've got to change the culture, you've got to incentivize good behavior, and you've got to help people to see that their patients will benefit, because they are there for the patients and they believe that. But it's multi-pronged and there is no magic bullet.
So essentially the three things you've mentioned are the effect of the legal system or legal condemnation in playing a role in ensuring that what is good practice becomes required practice. Secondly, you've discussed training, making sure that doctors start off on the right foot, if I can put it that way.
Yeah.
And thirdly, incentivizing those who are in the profession to do good for other people. Is part of that incentive process producing material which will show empirically that if you do this, you get better results than if you do that?
I think it is. After all, I was the Director General of R&D, and I was the one that set up NIHR so that we could generate much more evidence to move things forward to improve patient outcomes. In the NIHR, I was the one that made sure patients and the public were part of the decisions about what studies we did, because I believe totally in the value of evidence as the basis for changing and moving forward and improving patient outcomes and experience.
So it's presenting the evidence and hoping that evidence isn't, as you described it earlier, too much of a social construct, but that actually is listened to.
Yes, and trying to make it a norm for that part of our medical system, as it were, because people cleave to the norms. So if that's what everyone else is doing, why are you the outlier? And hence the role of audit.
So is there a competitive element in this? They're doing it over there, and they're the leaders. We ought to be doing it here?
Most doctors are a bit competitive, yes.
Well, we have seen signs of some of that on occasion.
Yeah.
So you, at the moment, I think, have a role or have a great interest in antimicrobial resistance.
Yes.
And that is essentially the problem of too many drugs causing infections to become resistant to those drugs.
Yes, overuse of antibiotics, for instance, push resistance higher.
And there must be a considerable reluctance, which one might have described at some stages as cultural, to not giving drugs, particularly if the patients are coming and saying, look, I've got this, give me something to deal with it.
Yes.
How are you managing it across the world? How are you convincing people to change their culture on that?
So, through evidence and stories, there are the two lines. So I felt we needed more evidence about the harm and persuaded the department, the Wellcome Trust and the Gates Foundation to fund a big study of the burden of disease. It came out 2 weeks ago. 1.27 million people die each year across the world of untreatable infections. 5 million, which includes that 1.3, die with antimicrobial resistance. It's contributed, so it's one of the top 3 contributors to death with stroke and heart disease. That's been very powerful. But then what do you do about it? Well, in low-income countries, there's access issues. But what we're talking about, I think, is misuse of antibiotics. So you then have to look at how can you steward what we've got. It's called stewardship programs, and some of that's education. And pharmacists can play a big role in holding doctors to account. I would sit in outpatients and the pharmacist would ring up and say, Dr. Davies, we don't any longer have that drug, or we don't use for community pneumonia this antibiotic, we use that, may we change it? So they can play quite a useful role in this. Guidelines have a role, but behavioural things play a role too. So, for instance, I wrote, well, it went over my name, Public Health England ran it, a letter to the half, randomly chosen, of the top 25% prescribing GPs and said, you're in the top 25% of prescribing. That year, prescribing went down 13% in that group as compared with the control group. And we went on and it continued to decline. Australia copied it and they got an even bigger rise. So you can put in place behavioural things. A lovely study about delayed prescriptions done out of Southampton. So a mum takes a child, my child needs an antibiotic, look ill, high temperature. And the GP says, I think it's viral, I think your child's going to be all right, but here's a prescription. If he's worse in 24 hours, you can cash it in. Use of antibiotics goes down dramatically, not totally. Another behavioural one, which I think is quite interesting, is run by Public Health England in the Northwest, was the general view is patients ask for antibiotics and make doctors' lives difficult. Well, then why do they want them? And if you do focus groups, they want to be able to ring at work and say, you see, I am ill, I've got an antibiotic. They need that. And they are ill. So they developed special prescription sheets where the patient's name was handwritten, a tick for what was wrong, a tick for what should happen, going through, but not an antibiotic because it wasn't needed, signed and dated by the doctor, torn off and handed over. And that worked really well at reducing them because the patient could ring up and say, I've got a prescription, I am ill, and the patient got something out of that consultation. So there are behavioural ways, and we have to do a lot more work on that side of evidence and what works.
When you say we have to do a lot more work, that's, again, going back perhaps to an aspect of research and development. It's certainly research. Who's doing it or who should be doing it?
Well, in general, it is the NIHR. When I left, I endowed Chris Whitty with an annual budget of 1.3 billion each year to spend on clinical and health research, and it included trials. Those trials were funded by that. And that was why I thought up the idea of the NIHR and argued so successfully for money, because we had to do research of a type that the Medical Research Council never funded.
Yes. Yes, well, thank you very much. I don't know if there are any further questions from anyone which arise out of that.
No, sir. Professor Davies, is there anything else you would like to say?
If I may.
Please do.
I wanted to say that, we all ask ourselves, can I do more? Could I do more? And I know for myself, and I think it's true for others, or many others, that we've worked as hard as we can to do our best for individual patients and the public. But I also want to highlight, I think that COVID and these events have shown us both the power and the insidiousness of infectious diseases. When I became CMO, I was told about the American Surgeon General, Dr. William Stewart, who said in 1967 that we could close the book on infectious diseases. That was wrong, and you've talked about why I am championing still the cause of antimicrobial resistance. Yet, as we've seen with the infected blood and the pandemic, it's not only difficult to find new and different infections, it takes us too long to develop diagnostics, even when we know it's there. And also, and I think importantly, in the minds of both doctors and politicians, we find it difficult to understand something new is afoot and shift how we do things. I think the other learning from this episode has, for all of us, been the truth that no medical intervention is risk-free. Everything from aspirin to simple tonsil removal or catching measles has risks. And I actually chose those three examples because I've seen deaths from all three. And I've spoken about that today, but we have to remember and help everyone understand that. This has been so tragic with dreadful suffering for the patients and their families. I'm glad the pain's been laid bare for all to see and learn from, but I am sad and sorry for the suffering. It was a tragedy for everyone who knows someone infected, but it's a tragic episode for our society as a whole, I believe. And I hope and pray that we all can learn and heal from this as a result of the inquiry. Thank you for doing it.
Well, thank you very much for the energetic evidence which you've given, the way which you've described and illuminated sickle cell disease, and what you can tell us about that as having been one of the first consultants to be dealing with that in the NHS. And on your observations from your time as a CMO, all your evidence has been of very great value to us, and I want to thank you for your time and your words in coming to deliver it. Thank you. 2 o'clock then.
Thank you, sir.
2 o'clock.